We are live now. Good morning, everyone, or good afternoon, or good evening, depends of which part of the world you're streaming, you're looking at us. I'm here, Luca Torregrossa, together with Dr. David Taggart and Dr. John Puskas, part of the International Coronary Congress and the International Society of Coronary Artery Surgery. We are here for a new appointment of the live talk. We call them coffee talk because generally it's morning in the East Coast of the United States. We take a topic of cardiac surgery, generally related to coronary surgery. And with a group of friends and colleagues in front of a cup of coffee, we want to have a discussion, a conversation. This discussion, it's a discussion in which all of you who are watching us can be part of. So please use the button of every comment button of every platform you are using to tell us where you are watching us from. And tell us also if you want to interact, ask us questions, and we will be able to see them and to get you in the conversation. The concept behind this live talk was started by the foundation of the International Society of Coronary Artery Surgery, created by Dr. David Taggart and Dr. John Puskas. Not only one meeting ICC every year, but also an opportunity every Saturday to discuss among friends and colleagues about a topic and learn something on a Saturday that you can apply on Monday morning in your operating room. So a real dialogue, an opportunity to push forward this community and to connect surgeons around the world that we all struggle in the OR. We all have that case that is more challenging. So we want to help each other. Before starting, I want to thank Medtronic. Has been an incredible sponsor of the International Coronary Congress, and today we are going to support this dialogue, this conversation around off-pump coronary artery bypass grafting, my learning curve. And before introducing all of the speakers of today, I want to remember to join us in December 4 to 7, 2025 in New York City for the 11th International Coronary Congress. Yes, this live talk are a great way to communicate and a great way to connect, but shaking hands in person, have the opportunity to speak and to raise your hand and to join is an extremely important opportunity. So come in New York City, join us, stay together. I want to go back and immediately introduce all of the speakers of today. We will talk about off-pump and how I learned it. And I'm very happy, together with Dr. John Puskas and Dr. David Taggart, to introduce Dr. Chase Brown from University of Pennsylvania, Dr. Lee West from Thomas Jefferson University, Dr. Hristo Kirov from Jena, Germany, and Dr. Gabriel Olivares from Allina Health, Minneapolis. The 30,000 feet view here is the following. Off-pump coronary artery bypass grafting that just 15 years ago was considered the most advanced way of performing bypass has lost some of his glamour, some of his interest. Major trial failed to show a benefit, but unfortunately, as we know, every paper and every big trial is exposed to flaws and to probably some innate mistake on the design of those trials. Somehow, off-pump that once was a requirement to find a job in the United States of America, right now it's a challenge. It's challenged by most of the cardiac surgeons. But here we are, young generation of heart surgeons, different parts of the world, interested in off. Let's figure it out. What's their training? How did they get there? Why they've been interested in off-pump? And how to get there, how to perform off-pump. So I start here with Hristo. You are the first person in my view Hristo, tell us a little bit. Where are you from a surgical point of view? And when was the first off pump that you have seen? How did you got interested? Why you perform off pump? What is the sense of off pump for you?
Thank you, Gianluca. My name is Hristo Kirov, and I work in the University of Jena in Germany. And I got lucky almost 15 years ago to start operating in an institution where everybody performed off-pump surgery. So it was an institutional expertise that just got me into operating. And much later, I started asking the question, why? Why is it better to operate off-pump? And those are the two main questions: why you should do it, and then comes the question how to do it. So I still remember when I was a young resident, I was assisting a Lima 2 LAD case open, and the surgeon said, "Oh, it's a nice target, it's a nice Lima, just come on my side and do the anastomosis." And after doing this anastomosis for almost 20 minutes, I tear the suture when knotting it. So that was my very first experience with off pump, but it is doable. I never had the chance to do a distal before. It was more than 15 years ago, but I still remember it. So it's doable, and I think it's an institutional experience. If everybody does it and everybody is acquainted with it, it's much easier to start operating off pump. And after that, I did my first 20 cases on pump, just to know that heart lung machine and converting might be an option. And after that, I started my experience. So that's it.
Thank you so much. Lee, Dr. Lee West from Thomas Jefferson. He's my neighbor here in Philly. He's a great friend. We were together in my operating room just few days ago. Lee, tell us a little bit, where are you from surgically, and why you're such a young surgeon? This is your first job in a big institution. You come in and the institution has never performed off pump, and you're bringing off pump. Tell us a little bit how you got here.
Yeah, so I would say the main reason I do off pump is how I was raised. I trained at UAB, and it's a very heavy off pump program. Jamie Davies, my mentor, he does 500 off pumps a year. And so I had the honor of doing probably about 300 of them in training. So something I was very comfortable with in training. And then when I got out to Philadelphia for my first attending job, I wanted to continue it because one, I think there is definitely a short-term benefit to off pump. You could argue the long-term patency rates, but looking at off pump patients in the ICU versus pump patients, there's a clear difference. But also it's a good platform to kind of start my minimally invasive practice. So I wanted to keep my off pump skills to start doing mid cabs and robotic CABGs.
Fantastic. Very good and solid point. Chase, similar background here. Like you come from a major institution. I always, when we talk together, I always says that you probably finish your residency at UPenn. You have done more Tyrone Davis procedure than coronary artery bypass grafting at the end of your training. And you probably have never been or exposed to off pump during your training, but then you went for a specific training in off pump. What is your journey? What was your sense? How you are practicing, and how was to come back in your own institution and practicing off pump? What was the feeling from all of your colleagues?
Yeah, good morning. Thanks for that introduction. I'm from the University of Pennsylvania, and was an integrated cardiac surgery resident. During my training, I got zero experience with off pump. None of the surgeons at the University of Pennsylvania did it. You know, occasionally, maybe they would do a sternotomy Lima 2 LAD off pump, but that was maybe once in my 6 years. So the goal for me was to hire me, to bring me on as faculty, but to send me away to learn advanced coronary skills. So I went to the University of Ottawa with Mark Ruel for about 3.5 months. And the goal was to learn, total artery revascularization, multi-artery revascularization, and minimally invasive approaches. When I left, I talked to the cardiologists who were very excited about this, that somebody was going to specialize and subspecialize in coronary artery bypass surgery. I talked about off-pump surgery, and they said, no, it's not something that we really think about or that we need. It just so happened that Mark Ruel does 99% of all CABGs off pump. So that wasn't a goal of mine when I went to him, but I certainly learned it, and I learned it very well. Over the 3.5 months, I did a lot of cases with him. And then when I came back to the University of Pennsylvania, I had this skill set, and the decision was, okay, I now know how to do multi-arterial grafting, all arterial grafting, minimally invasive robotic approaches to coronary surgery. But I also have this tool bag of off-pump skills, and should I do this? And my chief at the time was supportive, but he was saying, yeah, I don't really think you need to go down that road. It's going to be longer. Why don't you just use these skills that you've learned, but you don't need to necessarily do off-pump cases. But I think, as Lee already said, to do minimally invasive surgery, you have to know how to do off-pump very well. And Mark Ruel always said you have to learn how to do it in your sleep before you can do it through small incisions. So the goal was to just start doing off-pump cases. So I think I came back at the end of November, and then December I did my first off-pump case, which was a Lima LED and a vein to a diag. We started to build momentum with the team, and then slowly, we were able to develop an off-pump program. So I'll leave it for other people to talk, but that was my journey.
Fantastic. Thank you so much. Very, very, very inspiring. I think that what you're doing is absolutely important for all of us. Gabriel, Dr. Gabriel Olivares.
Yeah. Good morning, everyone. Thanks for having me, Gianluca.
Oh, you're welcome, Gabriel. And we met too in my operating room during a visit. We were discussing a little bit about minimal invasive, and tell us a little bit where you are now in Minneapolis. You're practicing. You are originally from Chile.
Yeah.
When was the first time that you have seen off pump during your training? Does off pump is practicing at your own institution currently, and what's the feeling? Why you want to perform it?
Yeah, I work specifically in St. Paul, Minnesota. We are a middle-sized hospital, so the most single common procedure is CABG. And after a year practicing as an on-pump surgeon, I decided moving because of the patients. And we start seeing more high-risk patients. Higher risk of stroke, higher risk of dialysis, and I said I have to do something different. If you want to really reduce the risk of a stroke, renal failure, you have to do it off pump. That was my thought. And during my training, I was not exposed to any of the off pump techniques. And after a year practicing, I was very comfortable doing on pump. But the reason why I moved out of my comfort zone was the patients, populations, high-risk patients. And ultimate, and also I would like to approach this as a minimal invasive approach. That's why I get involved in off-pump surgery. And I want to thank people like you, Gianluca, because I mean, the only reason because I move is because we watch all this stream and education, and it's important to support when we need to incorporate new technique to this operation. So thank you.
Thank you so much, Gabriel. Cardiac surgeons are not very famous to connect among each other, but I can tell you that the coronary surgeons are actually a very nice group of people. We like to hang out with each other. I think ICC is populated always by happy faces. I don't know about so Dr. Puskas, give us a little bit of the summary, and you're taking back here. You heard all of these young surgeons, practicing surgeons. What is your view as your expert? And I will ask the same after to Dr. David Taggart. So what is your thoughts after hearing these voices?
First, I'm delighted that we have a new generation of young surgeons taking up off-pump bypass and mastering the skills necessary to do it well. OpCab fundamentally offers the patient an advantage by avoiding whatever morbidity or mortality risk is brought to them by the use of the heart-lung machine, by cannulation and cross-clamping, by global myocardial ischemia, hypothermia, etc. So, as Lee West pointed out, off-pump patients generally recover in the short term more quickly and with lower morbidity than patients who are on bypass. In particular, blood utilization is much less common in off-pump bypass, so that in my practice, I do all the Jehovah's Witnesses from the Emory healthcare system, which is, it's just fine off bypass because the risk of requiring blood transfusion is a great deal less. But other than avoiding stroke and myocardial dysfunction from a global myocardial ischemia and aortic manipulation, I think that off-pump bypass, as Chase and Gabriel have pointed out, is a pathway to more advanced therapies, to all arterial, no aortic touch bypass, to minimally invasive robotic bypass and hybrid bypass. The totally endoscopic bypass that you're doing, Gianluca, may be the ultimate expression of off-pump coronary bypass surgery. So it's good for patients in the short and long term, and it's good for surgeons because it's a pathway to more advanced therapies. It is entirely unrealistic to think that in 2025, we should continue to do coronary revascularization by exactly the same techniques that were used in 1975, 50 years ago. We have to evolve, and off-pump bypass is the foundation on which we evolve.
Fantastic. Dr. David Taggart, give us your perspective in all of this. You're muted. Unmute right now. Please.
Thank you, Gianluca. And again, thank you for your enthusiasm and energy in organizing this meeting. As John has said, it's delightful to see some younger colleagues taking up the baton and saying we're going to run with this and explaining the rationale for it. It's not simply a matter of saying we can do it. You need to say, why are we doing this? And I agree with a lot of the comments of John Puskas. And what I would say, I started getting interested in this in the late 80s, because what you younger guys don't appreciate, bypass then was very different from what it is today. Going around the intensive care unit after a coronary bypass operation, watching patients, we used to have a term for it called pump head. Looking a bit like startled rabbits in a headlight, not so alive and conscious and awake, but not quite there. So the first thing to point out is it's very important to acknowledge the enormous contributions in the safety of bypass today, excuse me, compared to 3 decades ago. On the other hand, the patients whom we're now operating on are older, sicker, and have less tolerance. So that's why it's very important. I think as well that there is no surgeon on the earth just now who would say there is no role for a coronary bypass operation done off pump with a no-touch aortic technique. Look at the patient with a porcelain aorta. Who's going to tell you it's safe to cannulate, cross-clamp this aorta? It's not. And in my estimate, about 80% of patients in our practice today, it probably doesn't make a great deal of difference between on pump and off pump because of the improvements in cardiopulmonary bypass. But I think there are probably around 20% of patients who have a material benefit of being done off pump. The problem is, if you say, well, I reserve off pump for my high risk cases, it's a very dangerous strategy, because the last thing to do in a high risk case is say, I'm going to use a different technique. So you must be absolutely comfortable with off-pump surgery, preferably with a no-touch aortic technique as your standard operation. And as John said, once you get that right, it allows that to act as a pathway to further progress. So someone who wants to be a fully competent technician in coronary artery surgery must be able to do patients competently and confidently off pump with a no-touch aortic technique, but it must be done regularly.
Very good point. Very good point. So let me ask Dr. Puskas back again, and you, Dr. Taggart. Can you give us again, very briefly, and then we go for a new round of questions, but very briefly, summary of all of the off-pump versus on-pump trials. What do we get from there? The German veterans, the coronary. If you have to give us a ChatGPT summary in a 3 bullet point, what the study have shown and what were the flaws of the study? Can we really rely on the study right now, 20 years after?
That's a really important question. I think fundamentally, what we've seen is that very low-risk patients have very good outcomes with coronary surgery, either on or off bypass. And in a low-risk cohort, it's difficult to demonstrate a mortality or even a neurocognitive benefit of off-pump bypass compared to an on-pump operation done, especially with more modern cardiopulmonary bypass. I think that off-pump bypass surgeons should take some credit for the improvements in the heart-lung machine, better filters and pump heads and whatnot, cannulas that we have now compared to the past, because frankly, cardiopulmonary bypass has improved, and that's a good thing. But whenever trials have enrolled higher risk patients, we've seen greater benefit for off-pump bypass. Again, the risk models for STS and for the European Society are all based on-pump cases. Patients who have high risk for morbidity or mortality with an on-pump operation are most likely to benefit from avoiding the heart-lung machine. So whenever we looked at patients in a higher risk category, we see dramatic benefit for off-pump surgery. In the lowest risk categories, you cannot demonstrate a mortality benefit, frankly, because the mortality rate is so low either way. I'll also comment, and this is an important point for all of our listeners to understand. David Taggart designed and carried out the ART trial, and that trial was confounded to an important degree by surgeons essentially not following the protocol as he had intended it. Many of the patients who were randomly assigned to receive a single mammary graft also received a radial artery graft. And many of the patients assigned to receive 2 mammary arteries actually received only a single mammary artery. So there was a good deal of noise in the data for the intention to treat analysis that was published in the New England Journal. But it's important to look at the appendix of that paper and see that in the as-treated analysis, patients who received more than 1 arterial graft did much better than those who received a single arterial graft. And frankly, off-pump bypass lends itself to multi-arterial grafting. Again, it's a pathway to better coronary surgery.
Dr. Taggart, give us very briefly the summary of a little bit of the study. What is the taking back message?
Thanks, Gianluca. Very little to add to what Dr. Puskas has just said. In low-risk patients, because of improvements in bypass, it's very difficult to demonstrate any benefit. But there are certain groups of patients who are definitely better done off-pump, and we may come back to that. But the point I made earlier is, unless you're using off-pump surgery as a routine procedure for yourself, rather than reserving it for difficult or high-risk cases, you're not going to see the benefits of off-pump surgery.
You know, I'd like to just add one comment to that, because Dave is getting at a very good point. I made the comment that high-risk patients are done better off-pump, as he has done. He's also alluded to the fact that we need to maintain the skill of the surgeon and the surgical team to do off-pump bypass well.
Yeah.
And in some of the randomized trials, we had the opposite. The Ruby trial, for instance, done in the U.S. Veterans Administration hospital system, allowed surgeons who'd done as little as 20 off-pump bypass cases in their entire life to randomize patients in the trial. And the majority of those cases were actually done by the residents, scrubbed on the case. So it doesn't just matter which patients have the off-pump bypass in terms of demonstrating a material benefit. It also matters how the surgery is done. Let's face it, off-pump bypass requires a more meticulous technique. It is technically more challenging. It requires more teamwork than on-pump arrested heart surgery. And that's just a fact.
Yeah.
So that as we build expertise in the off-pump world, to use it as a platform to grow more sophisticated, minimally invasive and all arterial techniques, we have to remember that this does require a team, and the team has to work together to provide a very precise and reproducible set of anastomoses and bypass grafts.
Yeah, very good point. And we go there directly. Chase, Lee, Gabriel, you both come from institution where you don't, your institution was not practicing of pump before you guys joined. And Lee and Chase are in institution where you guys train residents, fellow. So it's possible that a morning you have a bypass, you don't know who is going to help you that day. A new fellow, a new grad, and someone new. How did you mitigate the learning curve of your team, of your assistant, of the person in front of you, and of your anesthesiologist? One of my anesthesiologists, Corey, just texted me and he's watching, and he told me, ask how they mitigate the learning curve. If for anesthesia, I remember a presentation of one of my mentor, Gino Gerosa, that in Italy, and he had this picture, and he said, off-pump bypass, there was the anesthesia in the room working very hard, and the perfusionist in front of a cigarette and a cup of coffee. And the on-pump bypass was the opposite. The perfusionist was working hard, and the anesthesiologist was smoking a cigarette and drinking a coffee. So in one way, your anesthesia needs to build up, your assistant needs to build up. How do you mitigate? We start with you, Chase. How did you mitigate who is in front of you that day? How do you manage the training curve of your team?
Yeah. So when I came back, luckily, there was a surgeon there who did off-pump surgery, but about 10 years ago. So there was still a group of anesthesiologists and CRNAs who had some familiarity with the technique, but it was a while ago. So it wasn't like I was walking into an institution that's never heard of it before. But many people have turned over since then. But there are some older CRNAs and older anesthesiologists who it wasn't like starting from ground zero. When I first started, I did the cases with the physician assistant, and then had a resident also, a younger resident also joining and scrubbing. The problem is I come from an institution that, prides itself on training, and it's high volume. So that only lasted for about, 3 months. Before then, the PA was over taking vein in the other room while I was with the, 4th year integrated resident. So that's hard, right? That's hard because you can have a different anesthesiologist and a different resident every single day, and it's really hard to create a group dynamic. So I think what people have said is true, is that off-pump surgery benefits about 20% of people. So for me, it was about finding a middle ground. I don't do 100% of my CABGs off-pump. I do probably, more like 30 to 40% of them off pump. And a lot of that is because of what my institution is like and the volume that I have to do and the residents I have to work with. Now that works out well for me. That allows me to have the skills that I need, that when I have somebody that comes in with a porcelain aorta and good targets, I can do it. Do I wish I could do 100% off pump? I do, but you have to think realistically what your institution can offer you and then form a game plan. I think it's a spectrum, and you have to find out where you're going to sit on that spectrum. And I think we can have an honest conversation about this, because I do think there is a valid argument that if you're not doing it all the time, that maybe you're not good enough to do it. I don't necessarily believe that, but I don't think you can do 5 a year and then do an STS of 25 with a porcelain aorta and expect to have good outcomes.
Completely agree. Lee, tell us about your learning curve of the team around you. You work with new residents. You are new in town. There's a lot of pressure. Everybody's checking your outcomes probably. If your patient sneezes 2 times in a row, is reported to the higher level rank of your own institution. So how did you mitigate the training of everybody around you?
Yeah, I think the Achilles heel of off pump is the lateral wall from a surgeon standpoint, from an assistant standpoint, and from an anesthesiologist standpoint. So we first introduced it as just limited LED and diag targets, and then we started pushing the envelope. Our anesthesia team is very good, but they were new to off pump. And the first couple of months, we were converting lower EFs at 30%, 35%. And as we all grew, we've gotten the conversion rate down to almost zero. We haven't converted in months, and we do, 20%, 15% EFs regularly now. So as we all kind of grew together on the lateral wall, I think they got better. The assistants got more comfortable, being able to blow in that compromising position, and then we got more comfortable sewing faster. So it took probably 6 months to get everybody comfortable, but now the conversion rate's a lot lower.
Excellent. Anesthesia, how did you manage that? Do you have anesthesia capable of performing off pump? Do you work with CRNA or do you work with anesthesia attending?
We have a CRNA, and then we most of the time have a MDA in the room. So, and our CRNAs are very good and can now handle a lateral wall target. We pace often, and then all the movements are slow, and we just talk about everything. Make sure everyone's happy before we set up, make sure everybody's happy before we open a target and commit, and then we move on.
Fantastic. Gabriel, tell us a little bit about your experience. How did you mitigate the challenges of your team? Who do you work with? Do you work with PA? Do you have residents? Who is your anesthesiologist? How did you handle the introduction of off pump in your institution?
Yeah, it's a private practice, so we only have assistant or PAs. It's only just one per room. So at the beginning, I request to my boss having two of them, and it is going to be one, the senior one, helping me. But to be honest with you, I think the most single factor is the surgeon patient. So I bring more patients to my room that day, and a good music, and just be relaxed and trying to be quiet. Sometimes it's not possible to have the same people in the room, which is painful. And every time you have to teach how to move to the assistant. So that is challenging. But again, if you bring extra patient and you try to be relaxed, you can make this happen. But it's hard. Yeah.
I love that. And I agree with you. Like I perform 100%, 98% of my bypass are off pump. Everything that comes is off pump. The 2%, actually, probably is a little bit less. It's 90%, and I have 10% of cases in which they have atrial fibrillation, and I go on bypass to do a MACE. My indication to go on bypass is MACE procedure. So, but it is hard, and you need consistency with your team. Hristo, tell us a little bit about techniques, lateral wall, inferior wall. What is the taking from you about how to perform it and how to get there? What is your suggestion for young surgeons that are listening to us? How do you first OM?
Of course, there are a number of tips and tricks that you can use. I personally, when going to the lateral wall, I play a lot with the table, and you need a good communication with the anesthesiologist. Normally, I do put the patient in Trendelenburg position. I'm sure that before I start, I have a good systolic blood pressure, and normally I tilt the table towards me when staying on the right patient side, so that I can have a good view of the lateral wall. And of course, using one or sometimes two Lima stitches, deep pericardial stitches, in order to be able to visualize the wall. I think probably the most challenging thing is how to touch and expose the heart without additional extra systole, or without getting into atrial fibrillation. So I think the slow and very gentle manipulation of the heart is very essential for the lateral wall. And this is something probably you have to see, but also you have to learn, and it comes with experience. There is a learning curve in off pump. I think there is one, but what I would recommend to everybody is don't start it on yourself. I think if you go and watch it into an institution where it is a standard, where everybody is very acquainted with this, you might learn this in much faster than coming or going through all the pitfalls yourself.
I completely agree. I can give you my recipe, and then I want to go through a quick round of everybody. How do you do lateral or inferior wall? My recipe for doing them are the following. So, number one, pericardial suture. When you open a pericardium, don't put your pericardial suture at the edge of your pericardium, but deep. The pericardial, and this is the concept of that I learned from Dr. John Puskas when I was his fellow, is an hammock. You can rotate the heart if you pull on traction suture. If you are pulling the left side, the right side always down. If you are pulling the right side, the left side always down. If you pull simultaneously, you choke your heart. Number two, I don't put any more deep sutures like I learned with Dr. John Puskas. I put a wet lap pad behind the heart. It's easier, it's faster to move in and out, and it doesn't have you, particularly in low EF or in arrhythmogenic, to expose and put the deep stitch down there. Just a lap pad wet behind the heart. As Lee pointed out, I A-pace everybody. I have those alligator clip, and I A-pace everybody at 80 beats per minute. So when I'm ready to expose lateral wall, I A-pace at 80 everyone. And then Gabriel said it, go slow, proceed slowly, delicate, very delicate, and you will be surprised how with the octopus and the stabilizer you can manipulate. Gabriel, microphone to you. Give us your recipe of your lateral wall, inferior wall. What do you do? And you are muted, sorry.
Yeah, well, I think with you, Gianluca, so you already gave the recipe. So yeah, that worked very well for me so far, Gianluca. As you mentioned before, those are great tips. What exactly do you do when you have those very tortuous vessels and you have two vessels very close to each other, so you don't want to put the octopus right on the top of the other one? So what you can do in those situations, Gianluca? You're mute. You're mute.
I am mute myself. Thank you. It's the echo on the back that is killing me. So I shunt everybody, and using a shunt helps me straighten the opening. And I think that helps making the vessel a little bit more straight and facilitate the anastomosis. This is in tortuous vessel, and I think it's valuable. Chase, how do you prepare your lateral wall?
So I think there's a lot of different, roads that go to Rome, and you can do this in a lot of different ways. The technique that I was taught is to use pericardial stitches and the urchin. So if you draw a line between the IVC and your left inferior pulmonary vein, you can kind of imagine an imaginary line that goes underneath the left atrium. And you can put two deep pericardial stitches in there. So you lift the heart, you talk to anesthesia, you say you're going to get your blood pressure is going to go down. You put your hand, you do a two-hand technique to get down there with the Raytech, lift the heart up, and then try to put quickly two deep pericardial stitches down in that area. Then put the heart down, let it recover, snare those sutures that you put down there. So when you pull up, you're not going to violin string and damage the heart. And then slowly talk to anesthesia and start to lift up on those deep pericardial sutures. When you start to lift up on those, the apex is going to enucleate from the chest and start sticking kind of straight up. Then you kind of have this rotating apex. And sometimes you don't actually need to use the starfish or the urchin. You could just go ahead and put on the coronary stabilizer. But I think you get a little bit of extra 15%, not only exposure, but stabilization. If you then put your starfish on the vessel that you are going to graft towards the apex, and then bring your stabilizer in over that, And I think people have mentioned it. It's all about communication. It's all about talking to your anesthesiologist. And what you don't want to do is look up and now your maps are 30s. And to prevent that, it's a constant communication. So if your blood pressure is going down, if things aren't working well, your anesthesiologist is communicating to you. So you can go ahead, put the heart down into the chest. They can work on giving volume, adjusting the table, or starting some starting some pressor. What you don't want to do is use epi. You can usually do these cases with neosynephrine or levofed. And those techniques generally get you a good exposure of the lateral wall.
I think that the lateral wall exposure clearly is the Achilles heel of the operation and the thing that intimidates surgeons most. You've heard the expression slow and persistent. I think it's important to make these maneuvers gently. I agree with Chase. There are many ways to get it done. Paul Sargent from Belgium described the use of a ribbon gauze, and that has become our norm. We actually place that deep pericardial suture exactly as Chase has described, but then we snare within that a ribbon gauze, sometimes called a vaginal pack, and that then gives us two ends of that gauze to use to rotate and elevate and enucleate the heart from the pericardial well. And that, in combination with the starfish, provides superb positioning of the heart with really minimal hemodynamic compromise, irrespective of how deep we have to go for our anastomosis or the coronary target. The concept of pacing is important. There are multiple advantages. Bradycardia provides too long a diastolic phase and the heart gets bigger. Ironically, pacing at 80 means the heart is smaller and there's more airspace around the heart within the pericardial space within the mediastinum. So while in the very old days, in the 1990s, we talked about slowing the heart down to make it easier to do off-pump bypass, with the octopus and starfish, we have such good stabilization that we don't need a slow heart rate. It's actually better to maintain hemodynamic stability, maintaining a heart rate of about 80. And then the surgeon and the team are used to working at that cadence. It becomes more routine and rote to get a perfect anastomosis.
I agree. Lee, what is your game for lateral wall? Is there anything else you want to add? Anything that you find difficult, challenging? What makes you sweat at night, the night before, when you're thinking, oh my God, I have to do that case. I have to do it off pump. I cannot sleep.
Yeah, I would say that one of the biggest shocks that came to me when I started doing off pump as an attending is not all lateral walls are created equal. And at UAB, we did everything off pump. And so I thought everything was doable off pump. And I quickly learned in the beginning that if it was a good target, if the target was close to the circumflex and very deep, it was going to be very hard to get to. So we really started in the beginning cherry picking not only good lateral targets, but big targets that came out more towards the apex and easier to get. And then the other thing we do, maybe controversial, is we open our sternal retractor pretty wide, and we use the bed aggressively. We don't have this at Jefferson, but at UAB we had foot pedals for the bed, so the surgeon controlled Trendelenburg, roll, every height of the bed, which was a huge advantage because we could do it quickly in real time while the heart was lifted. So bed movement and a wide retractor.
Putting a roll of towels. I'm sorry, David. Putting a roll of towels under the right edge, right limb of the sternal retractor elevates that right sternal edge and provides some space for the apex of the heart to even roll into the right pleural cavity. We, of course, have to open the right pleural cavity widely in that scenario, but that can allow one to approach the very high lateral wall without elevating the heart unduly. You actually are rotating it into the right chest rather than elevating it towards the ceiling in that scenario. That requires a relatively bigger chest, a relatively wide opening of the sternum, elevation of the right side of the sternal edge, and usually it's easier with a smallish heart. But that's one way to get to those high lateral wall vessels that might otherwise be very difficult to reach.
Yeah. Gianluca, I think so I agree generally with most of the comments that have been put forward, but I also disagree about the complexity of the lateral wall. To me, the most important thing in off-pump surgery is open the right pleura widely and divide the pericardium down to, but not through, the phrenic nerve. And if you do that, you can get 90% of hearts comfortably displaced into the pleural cavity, making the lateral wall as straightforward as the anterior wall. The only time I would disagree with that is if you have a very large dilated heart. Now, you can do 100% of your cases off pump. There is no time when you say, I can't do this off pump. But for me, when we have large dilated hearts, I tend to do those on pump. And it's because if you persist with these hearts doing them off pump, often the next day when you see the patient on the unit, their creatinine has gone through the roof, telling you that they were in a period of low cardiac output. So for 90% of hearts, if you open the right pleura widely, divide the pericardium, the lateral wall is as straightforward as any other part of the heart. That's my experience, in my opinion. The second thing is, I think the perfect communication in an off-pump operation is when you don't have to say anything to anyone. And this is where the team comes in. So if I'm operating on the heart, I'm not looking up at monitors. I'm not looking at the ECG. I'm looking at the epicardium in the area where I've got my stabilizer. Because if the heart begins to go off, I can see it there even before the anesthetist will say there's an issue. So if you've got perfect rhythm between you and your anesthetist, you don't need to say anything. They're watching what you're doing. They know what you're doing, and they're constantly doing what they feel to maximize the hemodynamics for you, so that you can concentrate purely on getting your graft correct.
I'd like to borrow your anesthetist. Usually, as Gabriel pointed out, we're working with a revolving door of teammates. So in particular, above the drapes, anesthesia residents rotate, it seems, every 24 hours, but actually it's every 6 weeks. So you're re-educating the anesthesia person. So, for me, it's a constant conversation, David. If I don't maintain conversation literally all the time with the anesthetist or anesthesia resident, then they're on their phone or they're doing something that isn't helpful.
John, if that's your situation, don't do the case off pump. You cannot, as a surgeon, if you've got an anesthetist who either willingly is uncooperative or who simply doesn't know what they're doing, I would strongly not do that case off pump.
Well, we do them routinely off pump. We just tell them what to do, and it's just that they follow directions.
So, as I say, if you're in that situation where you cannot have a competent anesthetist who knows what they're doing, I would not do the case off pump.
Fair.
No, it is fair. Hristo, tell us a little bit of what is your game for lateral wall. What is your what else you can give us for inferior wall and lateral wall? What else is your taking home message?
Well, I think almost all the tips and tricks that were said so far are universally agreed and understood upon. What I consider very challenging for the lateral wall is, as Dr. Taggart said, low ejection fraction hearts. As we know from the evidence that patients with low ejection fraction profit from CABG. So it is a prognostic indication, but they might turn out very challenging on when doing them technically. What we started probably around 1.5 years ago is putting a microaxial pump at the beginning of of surgery, then through the right axillary most of the time, then performing the surgery off pump, also anaortic. On that microaxial pump support, mostly we use the impeller 4.5. We've had excellent results so far, and this might be a very, very convenient way to do those very challenging cases. If you have a 15 or 18% ejection fraction with huge dilated right ventricles.
Yeah. I love this concept that you're saying. Basically, the concept here is you have generally when the left, and I check this one before going to the operating room, transthoracic echo, pre-op, the end diastolic diameter greater than 5.5, you know, those are challenging cases. I learned from John Puskas the term bad CABG, balloon assisted, is bad because it's a bad day. And back in the days, we put a balloon, we assist the patients with the balloon, we try to help them. And it's still relatively a good option to try to stay off pump. Yesterday, literally last night, we did with my assistant that everybody knows because she works every day with me, and we have a great teamwork. Amanda, we did a 25%, 50 years old, total arterial revascularization. We didn't need anything. We didn't need a balloon. We didn't need an impeller. But the concept here is when the LVAT is to be higher, around 6. Yes, you can go on bypass, you can, but arresting those heart, it's never an easy choice. And this heart never takes a cardioplegia arrest easily. So if you have very low EF, staying off pump can be useful. On pump beating is another strategy, but comes with a series of problems that were highlighted by actually a meta-analysis of Dr. Taggart. I think that the opportunity to stay completely off pump but assist with an impeller could be a good option. It can really help some subset of individual patients, particularly with very large heart. I truly believe, to go back to a little bit more normal type of patients, though, that off pump has a great advantage, and we still don't know the value of off pump. We have said that yes, the cardiopulmonary bypass machine are getting better, but reality is that our TAVI versus SAVR studies showed us that when you do an MRI early after surgery, you see a lot of signals in the brain of patients, more almost in the TAVR patients than in SAVR patients, but even in SAVR patients that are completely recovering well after the surgery. So the neurocognitive decadiment after heart surgery is not studied well. And I believe that one of the big opportunities that we missed in off-pump bypass has been the proximal anastomosis, the avoidance of cross-clamp side clamp the aorta. That is, in my opinion, the caveat that never showed a benefit in all of the study that we have done of a stroke benefit for off-pump rather than on-pump. Hristo, you want to say something? Please go.
Yes, Gianluca. I just wanted to say that except the stroke prevention, which is a very strong side of performing unaortic off-pump or off-pump without clamping the aorta, there is another side to it. And Faisal-Bakin's group published some years ago that just by starting cardiopulmonary bypass in patients that have liver dysfunction or cirrhosis increases 4.6-fold the mortality of those patients. And based on this, we analyzed our own institutional experience. We just published that 1 year ago, that if you have, we measure the MELD-XI, which is a way to measure liver and kidney function. So in those patients that have low MELD-XI, there was no difference between off and on pump in our group in more than 3,500 surgeries. But in those who had very high MELD-XI above 11, we found out that off pump has a very protective effect. So the mortality was significantly lower in the off pump. So in patients with liver cirrhosis now or damaged liver now, it's our standard that we always try to push for off-pump surgery.
Yeah, I love this concept. And I love also the concept that in all of the patients, like it's not only about the stroke, the stroke that gives you half of the body paralyzed. That is, thanks God, nowadays, after heart surgery, a very small, extremely small amount. But it's the neurocognitive decadiment, it's the depression after surgery, is grandpa being able to play Sudoku when after surgery, is the 85 years old being able to go back and play chess or crosswords in the same way in which he was doing before. How do you manage proximal? That is another huge game of off-pump. Dr. Puskas, you want to say something, please?
Yeah, Hristo made some very good points, and the earlier comment about the so-called pump head. Well, we avoid that entirely with off-pump bypass. The rationale, the logic, the intuitive appeal of avoiding aortic manipulation entirely during coronary surgery. Well, that requires off-pump techniques, actually rather advanced off-pump techniques, an all-arterial, no aortic touch approach. But with that operation, there is such an intuitive appeal that I will tell you about a third of my practice now is cardiologists and cardiac surgeons as my patients coming from out of state. I've operated on more of my surgical colleagues and cardiology colleagues since devoting myself to all arterial, no aortic touch off-pump bypass than ever before. And that's the ultimate compliment, but also validation of the intuitive appeal, the natural, the logical belief that this should be the least morbid way of achieving surgical coronary revascularization.
Completely agree. Absolutely. Chase, tell us, and then Lee and Gabriel, tell us, how do you manage your proximal anastomosis? We have the few minutes left of this live talk, and then we go for some questions. How do you do your proximal in off-pump, Chase?
So if I'm going to do it off-pump, because it's not 100% of my practice, oftentimes I'm trying to do it anaortic because there's porcelain aorta. I truly believe in what Dr. Puskas has said, that in true anaortic no-touch technique is the holy grail of this operation. And there's different ways to do that. You don't necessarily have to take an arterial graft and wrap it around the entire heart. You could take, the beginning part of a rima and extend that with vein and take that to a PDA. So I love doing that operation. One, it makes operations easier. You're not doing a bunch of sequentials. Dr. Puskas has a great video where he's talking about his anaortic techniques where he tries to make everything lateral. So you're not going around the heart doing a bunch of diamond anastomosis. That's a really good way of doing anaortic off-pump surgery. But if I do need to do a proximal anastomosis, I prefer to use a heartstring. And then I'll piggyback the other vein, so there's only one anastomosis. I can use the side biter, but I think the results have shown that probably doesn't help patients a lot when you put a side biter on the aorta. But real quick before I get off, I think you've heard a lot from experts, and this is just a call for the younger generation to really think carefully about coronary bypass surgery as a subspecialty. It's a really great way to build a practice, and there's a real need for it. And the United States, our multi-arterial revascularization rates are less than 10%. We're only doing 15% off pump. The Europeans are doing a much better job. So this is just a call for younger residents and fellows to truly get interested in this space.
Fantastic. Great words, Chase. Lee, tell us about your experience in proximal. How do you manage your proximal?
We use the heartstring for vein, and then we started after the recommendation from Chase. We use a radial as our second arterial conduit most often, and we take it right off the hood of the vein with the heartstring still in place, and that way you get directly over the aorta. It's a little bit higher risk because you're showing two anastomoses under one heartstring. So if you hit the heartstring, you have to take everything down. But we switched to that probably 6 months ago, and it's been really nice. So
great technique. My piggyback is exactly what I do for all of my proximal. It's also reduce the amount of touching of the aorta. You do one hole, and if you can close everything, that proximal anastomosis, I close with a core knot micro. And I do that because you can leave a little angiographic marker if ever that patient needs to go back for getting a proximal. You don't have if you have ever seen how they engage a proximal vein from the aorta, it's pretty scary. They go there poking around, and then they tell you that the vein is occluded, probably occluded then at that point. It's exactly that time. So leave a marker and let them being able to see it properly. But piggyback is a great technique. And for piggyback, we mean vein on the aorta and a second or vein or radial artery or a rita off of the hood of that vein that comes from the aorta, avoiding multiple hole, what I call the Swiss cheese effect on that aorta, multiple holes on the aorta, one single hole, a nice hole, and multiple proximal from there. Gabriel, how do you manage your proximal anastomosis?
Yeah, if I have to do a proximal, I ask the anesthesiologist to lower the blood pressure, and I use the heartstring. You have two sizes. I think it's the 3.8 and the 4.3. So I usually use the 3.8. And as Lee and you mentioned before, he says that when the heartstring is still placed in the aorta, you can do the rest of the anastomosis on the top. It makes things easier. Yeah.
Fantastic. I want to remind everybody also about the use of enclose. It's becoming now my number one choice for proximal. And the reason is that I love heartstring. I think that if the aorta is not super nice and clean, heartstring is probably best choice. But in a normal aorta, if you have to do a proximal, enclose give you way more bloodless field, way more control of your proximal, way less stressful than make the big hole, put a finger and insert the umbrella inside the aorta. That is always like a moment in which I go in atrial fibrillation. So I love to use a system that if you learn how to use it, yes, has two small holes, but it's so much more clean. Even particularly in Jehovah's Witness, if I'm doing a Jehovah's Witness, I never use an heartstring because the moment in which you're coming back off, you can have blood splash around. So it's a good technique. I want to go and wrap up for some few last comment. Dr. Taggart, give us a 50,000 feet view now of this group of surgeons. How can we wrap up and close? You're muted. Sorry. 1 second. I'm unmuting you. Yeah, please.
I'm doing what people like myself and John Puskas have advocated. The no-touch aortic off-pump technique is the holy grail. It's great to see a younger generation promoting this and going through. The only other final thing I'd say is, as we've heard, there are many ways to skin a cat when you're doing these operations. My own preference is to use as many arterial grafts as possible based on the inflow of two internal mammary arteries, which means you should rarely ever have to touch the aorta. But the final thing I think is very important and cannot be overemphasized is check your graft flows before that patient leaves the operating room.
Absolutely great comment. And I think that increase the value of off-pump as being the opportunity also to check your anastomosis and do it directly. That is another important point. If you don't perform off-pump, when you do an on-pump case, you release your cross clamp, and now you're checking your flow. One of the flow is bad. What do you do? The problem of surgeon not adopting TTFM is because that face you the opportunity to say, now what do I do? If you are an off-pump CABG, you just restabilize and redo that anastomosis because you believe that there is a problem. You have no idea, even in my hands, even recently, I've done a Lima to the LAD or I've done a PDA, and the flow was terrible. And I redid the anastomosis and the flow was excellent. And I couldn't even understand what exactly happened. Probably a stitch, a deeper stitch, a kink, or a way in which somehow, though, if you don't have enough pump abilities, redoing an anastomosis is a huge commitment. Is a second run of cardioplegia, is a second cross clamp on that aorta. And you end up saying, forget about it. It's just an OM. I can forget about it. And instead, it's absolutely fundamental. It's a technique that you need to have. Dr. John Puskas, give us your 50,000 feet view, and then we close this event.
Well, first, I want to thank you for organizing this again, Gianluca, and our panelists are very encouraging to see a younger generation of cardiac surgeons focused on coronary surgery. Coronary artery disease is the single disease that kills most human beings. As surgeons, devoting our skill and effort to combating the #1 threat to human mortality makes sense. It's a noble cause. It's worthwhile. Coronary surgery is worthy of being the focus of your professional life. And as we do that, if we focus on that, applying our surgical skills against the #1 killer of human beings, off-pump bypass becomes a necessary platform, a foundation to build more skills, aiming towards all arterial, no aortic touch off-pump bypass, and ultimately to doing that in a robotic environment, as you have done, Gianluca, with totally endoscopic bilateral ITA grafting. So OpCab is a platform. It's a chance to evolve your practice, to serve your patients better, to create new operations that deliver lower morbidity and better longevity in the future. Coronary surgery must evolve and improve. It cannot stay where it was in 1975. It will not continue to exist unless it evolves. And we as coronary surgeons have that obligation and that wonderful opportunity.
Completely agree. I want to share one more time the invitation to come and join us at the ICC 2025, the 11th meeting. It will be held in New York, December 4 to 7. Please come and join. Absolutely great opportunity for a lot of young surgeons below the age of 40 also to come with an extremely competitive price. We will have also some challenges. We will have a knowledge challenges about the know-how and culture of coronaries and a technical challenge on performing anastomosis. The winners will win a fellowship in any place of the world paid by us to learn and advance their practice in coronary surgery. I've said that. I want to thank everybody who have watched us from around the world. We had so many national comments. We have so many questions. I would say that it's really inspiring to see all of the people that are with us. I think that there is a future for coronary artery bypass grafting. The future of off-pump relies and stands on the shoulder of fathers and founding fathers of these subspecialties, but also on the next generation that is here to adopt a minimal invasive cardiac surgery and minimal invasive robotic coronary surgery. And off-pump is the pivot, is this essential tool to make that happen. So I want to say thank you again. And I want to thank for our panelists, Chase, Lee, Hristo, Gabriel. This is Saturday morning. We know that there are wives, kids, friends, family, fathers always pulling us. My daughter was here just asking to close this one and start playing with her. So I think it's time to go. Dr. Taggart, thank you for being here. Dr. Puskas, well, looking forward to see everybody in New York City, guys. See you in a couple of weeks for a new appointment of ICC Live Talk. I ask
Gianluca, very well done to you for organizing this super program. Really well done.
Thank you. Thank you so much. I ask you everybody to stay here. Don't log out. And I end the stream now for our view.